The next lectures by Dr. Prasanna from India, and he is a professor in charge division of neuroanesthesia in Jawaharlal Institute of Postgraduate Medical Education and Research Center in India. And he is going to talk about the controversies in brain death declarations, legal and ethical implications in ICU. Welcome, Dr. Prasanna, and I'm sure you will enjoy his talk.
Thank you. That's it. So, thank you, and thank you for making me a part of this August panel on the discussion of brain death and other the controversies. So, in the next 15 minutes or so, I am going to deal with controversies in the brain death declaration. What are more of ethical and legal issues pertaining to the whole world? So, some of these are covered by Professor John and Professor Jose in their previous lectures. I am going to reiterate few of things and few in addition to that. What are the controversies surrounding this brain death declaration? One of the most important controversy surrounding this brain death declaration is, despite of more than 50 years since the publication of the first criteria for the diagnosis of brain death or the determination of brain death, we are still not able to convince majority of the medical community and the public regarding the brain death as a form of death. It is equivalent to a death by the cessation of the circulation or the respiratory function. So that is a major controversy surrounding the brain death declaration. And in the next 15 to 20 minutes, I am going to deal with this topic. Greetings from my hospital, JIPMER. JIPMER is a 3,000 bedded hospital, a tertiary care center directly under the supervision of Ministry of Health and Family Welfare of India. And it's an institute of national importance in India. So moving on to the topic, we know that declaration of the brain death is challenging despite the 50 years of the guidelines. It still remains to be the controversial, though it looks like a simple algorithm, but it is a complicated procedure and it has a lot of legal and ethical implications. And more often it comes in the news and in the media, frequently associated with controversies. So hence applications of these tests in an ethical and legal manner is more important to have more public awareness and to improve the chances of brain death declaration and subsequent organ donations. So it started with this first paper, A State Beyond Coma in 1959 in Paris, that this discussion of whole brain death started that it is a irreversible condition beyond the coma where the patient cannot be made to recover. After this, many of the paths have been passed. The brain death journey has been superb and many guidelines have been published, including the AAN guidelines in 1995 and the AAN updates for these guidelines in 2010 and 19. So all these guidelines, what they have tried is to provide more and more clarity on the declaration of the brain death, also regarding the ethical and legal aspect of it. So it was the first criteria under the chairmanship of Dr. Henry Beecher in August 1968. The Harvard ad hoc committee formulated this criteria for the brain death. Essentially, it involved two parts of it. One is to determine whether there is a permanent non-functioning brain, and B is to confirm this data by the EEG. And the committee also suggested that in the absence of the EEG, the clinical criteria alone can be considered for the diagnosis of brain death, and it suggested to do two tests on 24 hours apart. During this time, when this committee sat up and gave the recommendation, a lot of changes happened surrounding the medical field and the quality of the treatment of the patient. With the introductions of iron lung, the epidemic, polio epidemic, and the introduction of positive pressure ventilators, there was improvement in the ICU care. There was increased number of ICUs which were available now, and there was improved quality of care and the survival also. With this survival came whether really are we improving the quality of life, whether there is a meaningful outcome when the neurological functions are not intact. These are the discussions started cropping up between 1960s and 70s. At the same time, on the other front, on the transplantation side, a successful brain dead organ donor was taken for the kidney transplantation. Also, the heart transplantation was conducted. So this, with the availability of these two, that balancing, most of the time it was thought that the committee wanted more and more organs for the transplant. Hence, this criteria was pushed. From this day, the controversy started. However, this criteria, as soon as it came, it was widely accepted. It was an all-physician committee and individual states, but the individual states immediately accept, though they accepted this criteria, they came up with different policies. And what happened because of this, that brain dead in one state was alive in the another state because of the definition. This led to further social doubts, whether is this being done only for the want of organs. That was the doubt which started along with this. To clear the air, the Informed Determination of Death Act was formulated in 1981, including not only the physicians, but also the bioethical and the other social people. And it gave the definition of circulatory and the brain death differently as a form of death. In India, the brain death law was passed in 1994, but it was passed as a part of transplantation of human organs. So our brain death criteria all are associated with the organ donations. Hence, there is more risk of controversy or legal or ethical issues when this brain death determination is being done as a part of transplantation. Then in the American Academy of Neurology, along with support from other societies, published the guidelines in 1995. And the guidelines clearly stated that it has to be based on clinical criteria. And these are the ones which are still commonly being used. It says that we have to determine irreversible coma. We have to see the absent brainstem reflexes, and the apnea test is an essential part of it. And it has to be done at a gap of 6 hours by a neurologist or neurosurgeon. And the ancillary test, lot of time the criticism came because previously the confirmatory test, the name was used. So hence, to avoid that, it was renamed as an ancillary test, has to be done only in case of clinical ambiguity. So again, the updates were published in 2010 and 19, which are widely accepted by all. But where is the controversy? Are we crystal clear in diagnosing brain death? When we look across the terminologies used by across the world, it is death, brain death, death by neurological criteria, cortical death, brainstem death, total brain failure, whole brain failure, all whole brain death. So there are several different nomenclatures are being used across the world, across the states in each nation. So this has led to lot of confusion in the controversies. So even 50 years down the lane, we are not sure about the nomenclature, what has to be used. In India, the law is widely accepted from the law of the UK. Hence, we term it as a brainstem death. So several other nomenclatures have been proposed. What are the ambiguities or controversies in this? When we look and do the 2 tests of test and declare brain death, there are several requests from the family members to continue care after testing. So in India, it is associated with brain death, associated with always organ transplantation, which is similar in many other countries. And suppose the family members are not willing for the organ donation and they are requesting for continuing the care of the patient. When this has happened, it has left to a lot of legal proceedings, and the court rulings have been contradictory to each state, forcing changes in each institutional protocols as per the court proceedings of those countries or states. And there have been some clinical or investigational changes, and there are a lot of religious interventions from few religious people that according to our beliefs, we do not want to be organ donor so hence do not apply these tests of brain death on our people. And there are undue media coverage and improper public awareness when we say that a brain death declared patient woke up and started walking next day. So most of this time they are due to improper application of the test, not because as such the brain death patient recovers. So these are the ambiguities or the controversial areas which are there in the brain death declaration. Now consider this scenario: 67-year female, unresponsive, like she has all the features which can satisfy brain death, but there is no clear cause for coma, why she is in coma. And the son is a foreigner who is staying in foreign and he wants to go back home and he wants to donate the organs. Is it possible? It is very difficult because one of the first criteria which suggests that the cause of coma should be known. So here it is not known. Similarly, the 25-year-old female with a male with a snake bite and he is unresponsive. Can we declare based solely on the clinical criteria? Looks very unlikely because we have to do some additional tests. So the algorithm looks simple. Are we performing the test correctly? So this was one of the paper which reported in 3 major institutions where 225 people responded, out of which 78 had done brain death determination. And 76% of this said that they claimed that they had brain death certification course. They have undergone this course and they are certified in declaring brain death. And to surprisingly, the results were 25% did certification, only 25% did certification as per current guidelines, and 10.3% didn't even report completing the apnea test. So not doing the apnea test as of now is currently inconsistent with brain death. So it cannot be done. Similarly, nearly 1/3 of the people ordered ancillary test when the apnea test was negative. So when the apnea test is negative, that means the patient has a breathing effort. Still, they ordered an ancillary test, leading to the confusion. Now, supposing you order a EEG and it is flat, whether you call him as a brain dead or he is alive. So those are the controversies which arouse. And there are controversies in testing also, like a pupillary dilatation. What is the exact size to say that it is dilated? Fully dilated, mid dilated? How to perform exactly the pupillary light reflex? And oculocephalic reflex is one of the most contentious areas. In a lot of the countries or states, it does not feature in the diagnosis or determination of the brain death criteria. Few countries still do follow oculocephalic reflex. In India, it still constitutes a part of this law. So whence we carry out these tests. And there are testing issues as far as the apnea tests are concerned. How do we oxygenate these patients? Is it through a suction catheter? Few people have advocated to use CPAP. And there are few conditions where it is very difficult to disconnect the patients from ventilator who requiring a higher positive end expiratory pressure. In those patients, it has been claimed that you use a low tidal volume and a lower respiratory rate to achieve the target PCO2 as early as possible with oxygenation. So laws are not very clear on this. And few people have even suggested to induce or institute a PaCO2 so as to get the PaCO2 levels of 60 as early as possible. Laws are very not clear on this, nor the evidence is clear on this. The testing time, whether you do it for 8 minutes and 10 minutes, some of the states it says 10 minutes, some of the states it says 8 minutes. What is to be done is not clear. And test numbers, whether you perform the test or number 1 time or 2 times. As per the most of the guidelines in most countries, you have to do 2 tests 6 hours apart, and pediatric it changes, but there are no clear guidelines and few centers are doing a single number of tests. Few centers are doing 2 tests for irreversible brain function and brainstem reflexes and only 1 apnea test on the second time. And if the PaCO2 does not rise, then it is told that you do ancillary testing. So what are the other issues? The temperature, the basic prerequisites for the apnea test, whether you need it as a 32 degrees centigrade or 36 degrees centigrade. In Canada, it is accepted to be 32, but in India and US, it is 36 degrees centigrade. So performing tests also differ from countries to country. And there is a time interval for the apnea testing, which differs from age of the patients. And still the rules are not clear when the premature neonates are there, less than 30 weeks, what is the time duration for this. This all adds to the confusions for the physicians. Are we doing it correctly? In the ancillary testing, it is the same, though they are available. There are some false positive and false negatives. And there is expertise in interpretation required, particularly when we are using EEG or nuclear scans. And many of the times, the patients will not be stable to shift them to either cerebral angiography or nuclear scans, thus adding to more confusion what to do now when we are not able to do an apnea test in these patients. Then who can declare? So the commonly accepted is neurologist or neurosurgeon. Now the criteria have been rapidly expanded to include even the anesthesiologist and intensivist. In India, the recommendation has been made to increase to anesthesiologist and intensivist also. In India, 4 people are needed to declare or determine brain death, whereas it varies from state to state. In a lot of states, 1 person is enough to declare brain death. So the big question here is, Are they trained in determination of brain death? Not a part of curriculum during their training. Most of the places, it is brain death determination is not a part of training. And many centers do not have even a brain death certification committees yet. So when it is not there, the person, even if he is a neurologist or neurosurgeon or intensivist, is he qualified or is he trained enough to do a testing? So when these are not clear, when they are not undergone the training, then it is likely possible that the application of the test also will be wrong. So once we declare brain dead patient, what is going to be next? Can you disconnect from ventilator? Many countries, yes, the brain death is a death, you can disconnect. But in India, since it is linked to organ donation, it is very difficult and we are not disconnecting them from the ventilator if the patient says that they are not ready for organ donation. But the Kerala is the first state in India to adopt this policy. Rapidly, the other states are following. They have said very clearly in categorical terms that you can disconnect from the ventilator since it is a death. Do they recover from here after the declared brain dead? So many media reports and few physicians claim that, but the 2010 update clearly says that there is no recovery. No patients who was declared brain dead using the clinical criteria has never recovered from here. Then the neurological criteria, are they legally accepted? In few of the countries, they are not. This was a classical case and the patient was declared brain dead, but the parents went to court saying that the therapy has to be continued. The district court said that since she is accepted as brain death as per AN guidelines, she is brain dead or she is dead. But the Supreme Court ruled because these AN guidelines were not accepted, or it asked whether they are the accepted standards of the guidelines. So later these laws were amended in the Nevada, but in this case particularly, it was rejected. So that is the problem in the current existing system, that though the standards are same, though we are trying to look at the irreversible brain function, the language and requirements are different. Like that, few of the states, the death pro forma asks how many attempts of CPR are done. So we know that in determination of brain death, we do not do CPR. Then there are a lot of clauses who can pronounce and what is the religious beliefs, whether to accommodate or not. So these are the different questions which continue to haunt us. This was one of the case. The patient was declared brain dead in California. The court pronounced brain dead, but the parents wanted to continue. So they went to the court and finally the patient, with the consent of the hospitals, was shifted to New York and she was put on ventilator. She survived for another 5 years. So New York is the state currently which allows for religious beliefs, and you cannot declare brain death if the patient cites that because of their religious beliefs, they are not agreeing for declaration of brain death. So organ support after brain death, neurological criteria, nearly half of the people ask for continuation of support. That is the problem. The families will not lose hope, they continue, because that is the level of public awareness we have. And physicians are also not totally aware of the laws of different states. So they are in a dilemma whether to discontinue the treatment or discontinue the ventilator or not as per the law. So the AN says that the current position statement reiterates that brain death is a biological reality that is measured objectively. Delaying declaration of death can lead to deleterious effects on patients and their families. And that physicians have both authority and obligation to conduct examination for brain death as a circulated death in a timely fashion. So it equates this brain death to the death and it has to be done as early as possible. So requests for short-term accommodation, that is the crucial point, based on the sincere social, moral and cultural grounds, has to be taken in consideration and it should be addressed as per the institutional policy. So it requests institutions to make policies. Who can give, or whether you need a consent for testing. In majority of the countries or in the states, it is not needed. If the physician feels the patient is brain dead, he can go ahead with testing. But in India, it is not like that. It is linked to organ donation. So we need to take the patient's consent and relatives for the performance of brain dead testing. One of the most controversial areas where medical, legal and all ethical issues are there in brain death determination is during pregnancy. So pregnancy and the patient becomes brain death. What are we going to do? Whether we have to see the fetus right to live, or cost of continuing the support therapies, or dignity or autonomy of the patients in death. So for example, if a 20 weeks, 24 weeks patient, pregnant patients becomes brain dead because of a intracerebral hemorrhage, are we going to continue the treatment till the patient or the fetus becomes viable and then discontinue? Are we going to bear the cost of continuing for 7 to 8 weeks more? Or what is the dignity or the autonomy of the patient in death, whether we want the patient to peacefully die? So these are the questions which are going to haunt us. There is no clear answer as of now. So many states say no withdrawal of supports. You have to continue till the circulatory arrest happens. Some states say that, for example, if the fetus is just into the viability time, like 28 weeks, you continue for some time before disconnecting the ventilator. And the other states say that autonomy of the patient, if the patient has shown its willingness not to continue the treatment, has to be honored at these times of pregnancy. The newer ICU modalities what are coming today, particularly after COVID, we have seen that many patients are being put on advanced hemodynamic supports like ECMO. And it has a lot of initial problems or the problems with declaration of the patient of brain death. There are several issues along with this. One is these patients, when they are put on this ECMO, they are high likely of injury, neurological injury due to comorbidities and other conditions. And also due to anticoagulation, they have a high risk of intracranial. But these patients, when we are suspecting them to be brain dead, how to conduct apnea test, how to conduct the other test is a big dilemma, which is still not yet answered. Many people have suggested to include the carbon dioxide in the oxygenator and check at the level whether the patient breathes. But the complexities are many and the performing declaration tests are very difficult, particularly the apnea testing. Hence, it is still not clear what are we going to do in those patients. So we need to have a clear defined legal terms. What are we going to do in these patients? Now, what about the public perception? Most are not aware that it is also a death. So we have to convince them that whether it's as similar to cardiorespiratory, it is also a form of death. And there is a lot of the time, there is not clear communication from the institutional or the physician side and the information given to the patients. As it is associated with organ donation, though many people tend to believe that because these people need organs, so they are doing the brain death testing. And many a times what happens after the brain death is declared, and when we are potentially looking at the cardiac and the lung donors, many tests are being instituted for like fiber optic bronchoscopy or a coronary angiography. These are the time it all adds to the complexities that patient may feel that their patient may be alive, and for the sake of organs, these tests are being instituted. So a clear communication must be needed. And also the public may be expecting some incentive or bill waiver for being a part of organ donation program, which currently most of the states are not doing it. So that's one more issue. So the President Council report in 2008 criticized most of the earlier criteria, and it termed the coin whole brain failure must be used, particularly to say that patient is not able to take care of himself. Even that has been questioned, like in patients with persistent vegetative state or in anencephalic babies, whether to consider them as brain death is not clear. So it is not because they have their own breathing efforts as per the current guidelines. So there are ifs and buts everywhere. So can we overcome at least some of these controversies or the legal and ethical issues? Yes, what is the need of our is we need to form a uniform guidelines at least at the national level, if not at the global level. But however, we have to move towards bringing the consensus at the global level and considering all the government health policies to have a uniform definition across the globe what we are going to term it as a brain death and what are the criteria going to be followed. There is a lot of need to define who can perform. We need to have training and education for the postgraduate, specialty level training, add the brain death into the curriculum. Still, after this, many can miss because the lesser number of the brain death patients being declared, particularly in the developing countries like India. So we need to have resort to the newer methods of training, and we also need to expand people who can perform. For example, if I am going for a testing, I can take one more trainee along with me to train him as a part of mentorship program. This is one of the important toolkit which all of you can go through. It's a paid toolkit from the Neurocritical Care Society, which has been designed on a video session based lectures, how to determine the brain death, what are the criteria and what are the legal implications. It is endorsed by American Academy of Neurology. Please go through it and you can. So that's how the training can be improved. Simulation based training is one more good aspect of it. It helps in better learning, stress-free environment, improves knowledge and confidence, and also areas of error and improvement can be assessed and corrected in an individual. Improving the awareness among the physicians is the most important aspect of any brain death determination program if you want to sustain it for a longer future. Include these discussion at the medical school level itself through didactic lectures, video sessions, generating free online content, and presentation of day-to-day happening around you regarding the brain death and organ donation. The legal system should closely work with medical, bioethical, and the government and policy makers to find out nuances in law and take a corrective action. Because if we are afraid of a legal proceedings or a law, then we will not be performing wholeheartedly for it, particularly when it is not associated with incentives like in the government sector or public sector hospitals. So we need to find the nuances in the law and work closely with the legal system to correct these things. So awareness among public, it is very important. So more visibility in the form of media, we can make movies, more power to the NGOs like Mohan Foundation is doing a fantastic work in India. We can have video demonstration or displays in public areas and encouraging short movies on life after death. So these are few of the programs which we can do to bring awareness in the public. So this is my last slide. To summarize, the AN update of 2019 solely concentrates on these issues, that it suggests to form uniform institutional policies for brain death determination within US medical facilities, training programs for physicians who determine brain death, credentializing mechanisms for physicians involved in brain death determination, regardless of specialty. That's the most important aspect. It should not be fixed to only neurologist, neurosurgeon, anesthetist, and intensivist. It should be for across the specialty. Institutional policies that ensure compliance with medical standards for brain death determination. Research that enhances and the brain death knowledge base and the accuracy of its determination. And also enhance professional and public education regarding these considerations. Thank you for patient hearing.
Thank you so much, Dr. Prasanna. Very interested. And you actually talked in many issues, medical, legal, awareness. Yeah. Actually, at the moment,